Okay. Well, hello everyone. This is Juliet Choi with the Asian and Pacific Islander American Health Forum. We are here on a Friday morning, afternoon, maybe later in the day, depending where you are. Thank you so much for taking time out of your very busy schedule to join us. We've heard from many of our community partners. We're really thrilled and honored that you would take the time out of your busy schedule to join us today. We've heard from our network of partners, and we know that the new CMS work requirements as it relates to HR1 has been top of mind for so many of us across the country, both internal to the Asian American, Native Hawaiian, Pacific Islander communities, but literally every community is being impacted. So, what we're hoping to accomplish today, again, based on your feedback, your questions, and your requests, is to try to provide a very quick and brief overview of the CMS interim final rule Medicaid work requirements. I know that's a mouthful, and some of you are seasoned policy advocates. You read the law, you read the regulations, you read the draft regulations. And within our community, we also know that there are community leaders who are wearing 10 to 12 hats a day, and you may not have the time and or this may not be your area of expertise to really take the opportunity to think about how some of these policies and regulations out of Washington, D.C. are impacting your work and the clients and the families that you serve day to day. So what we'd like to do is provide a brief overview of what the Medicaid work requirements are shaping up to look like. We also want to just share a note why, for us as a community, it is important for us to have a working understanding of when there are regulations, why it matters for us to be able to say something publicly, which, thanks to you, the Health Forum, that is one of our primary areas of activities here in Washington, D.C. And I'm very excited, I'm very honored and humbled that we have some extraordinary community leaders who are willing to join this conversation today and share with us what they are experiencing, what they are hearing on the ground. And I think this is going to resonate for a lot of you. I'm also hoping that through this conversation, it will give you some ideas to think about, literally some concerns to work through, take into consideration what else you may want to take into consideration and plan for later this fall and working into the end of the year and rolling into the new year. So again, we've got some terrific community leaders who are joining us today. I am going to walk through my overview relatively briefly because I want to make sure we allocate at least about 30 minutes for our wonderful community leaders. And then my hope is to try to allocate at least 15 minutes of Q&A and comments. We may not get the chance to hear from all of you. So please, if there's a question, if there's a comment, if there's an idea, please drop it into the chat box. What my team and I will be doing afterwards will be curating all the comments we receive. And then afterwards, never hesitate to reach out to us if you think a conversation like this would be helpful for all of us going forward. I'm looking at the Zoom ticker, including the speakers. We have almost 70 of us who are here today. I expect, hopefully you can spend the next 45, 50 minutes with us. You may need to drop off. This is being recorded. And for our speakers and for myself, please know that we will never be disclosing individual information. I think it's important for us as a community to be able to state that up front. So without further ado, let's see, let's go to the next slide. So the interim final rule, next slide, please. All of us have been impacted by HR 1, which became law July 2026, exactly 1 year ago. And once legislation is passed, it is then directed to a federal agency to create policy and guidance on how to implement and operationalize a new law. So, here, for example, the Center for Medicare and Medicaid Services, or CMS, what they did do is on June 1, just a handful of weeks ago, they issued what is called an interim final rule. I'm not going to get into the weeds on this, but when you hear the phrase interim final rule, this is pretty much the policy and the guidance CMS is going to begin to implement with a very short window for public comment. There are public comments about this interim final rule are being accepted through July 31. And what I do want our community network to be apprised of is that the Health Forum, and together with some of our national and local partners, we keep a close eye on the critical regulations that are being promulgated by Health and Human Services. And it's really important to make sure that for our communities, we're able to put some comments on the record. I'm going to come back to that a little bit later. With the interim final rule, or IFR for short, focused on work requirements, focusing on those who are Medicaid beneficiaries. For AA and HPIs, this is going to impact 4.5 million of us, including 1 million seniors. I think an important footnote here, especially for our community leaders on the ground, almost 500,000 of our seniors are going to be both Medicaid and Medicare dual eligible. So for those of you that are working with seniors who have dual eligibility, I just want to thank you for your incredible work helping our seniors navigate this unnecessarily complex system. These work requirements are going to be effective January 1, 2027. Some states will be applying for waivers. We're going to see how that plays out. So we don't have any concrete answers on that as of today. But what we do know right now is that 4 states have already implemented their own state level work requirements. Because as most of us know, Medicaid is both a federal and state jointly administered initiative. The 4 states that have already implemented work requirements, as you can see, are Georgia, Arkansas, Nebraska, and Montana. We know our communities particularly reside in Georgia, Arkansas, and Nebraska. What we've also learned is Iowa is set. They've done their own state planning, and they're preparing to implement their work requirements effective December 1. Next slide. So here's a brief overview of what the Medicaid work requirements look like. So in a nutshell, if you are a Medicaid beneficiary, and we know there are many more folks who are able to become Medicaid beneficiaries as a result of Medicaid expansion. So especially for those of you that are states where you have Medicaid expansion, your Medicaid population is going to be significantly larger. The work requirement, in essence, outlines by CMS that in order to maintain and continue to be eligible to maintain your Medicaid, you must demonstrate a monthly income of 80 hours of work at the federal minimum wage, which equates to $580 a month. Redeterminations of your work requirement, according to CMS, is going to occur every 6 months. Now, the 80 hours work requirement can also be satisfied through a combination of different activities. If you already work 80 hours a month, then you satisfy the work requirement. Alternatively, you can satisfy this requirement through a variation, a combination of paid work. You may participate in a federal or state work program, which means for each state, you are going to need to understand what is your state outlining. And I think from a national advocate standpoint, I think this is incredibly challenging because now this puts the onus on state-led coalitions and our local partners to have a better understanding of what is unfolding at the state level. You can also be enrolled in an educational program, for example, in college or a vocational training or vocational skills training institution. Additionally, this last point I think is going to be really important is you can also satisfy this through an unpaid community service within a structured program that is either overseen, administered by a public organization, which means a local or state government agency, or a nonprofit. On this one, I'm going to put an asterisk on this one and come back to it a little bit later, probably during our Q&A discussion, because I want to make sure we highlight some things we can think about as a community going forward. Now, those are how you satisfy the 80 hours a month work requirement. There are exceptions to this work requirement. This is not an exhaustive list. And again, for today, I wanted to make sure we outline the major framework. But again, these exclusions and exceptions, this is not an exhaustive list. Pregnant, postpartum enrollees are not subject. Those claiming short-term hardship, exceptions. Caregivers, disabled veterans, medically frail individuals, and if you are sitting in policy conversations at the local or state level, you know that a lot of organizations are really honing in on what does medically frail individual, what is that definition, what is that really going to look like as defined by your state. There are individuals already subject to work requirements under SNAP and TANF. Federally recognized American Indian, Alaska Native individuals are excluded. Those enrolled in substance abuse disorder, or another acronym is SUD, treatment program enrollees. What's at stake here? I think many of you already know. You can contemplate. A lot of us experienced this during COVID, for example, when we were helping our community members navigate Medicaid enrollment or re-enrollment. So at the application stage, your coverage may be denied. That's a challenge we have always faced, whether there may be a culture or language barrier to application. There may be lack of full documentation. At renewal, existing coverage may also be terminated for the same reasons I just stated. Also, some individuals may lose eligibility for non-compliance and may also be barred from subsidized marketplace coverage. And last but not least, people may reapply, but when you reapply, this may mean, depending on your state, that you may have to start the entire eligibility process. The biggest footnote here is there are so many barriers for our communities. You know these firsthand. And I do want to say that given the short timeline on the implementation of the work requirements, again, which is effective January 1, state governments are also really in a scramble to figure out what is their framework, what kind of guidance and guidelines are they going to be able to publish, and what kind of community engagement and assistance will they be able to lend to you. So what this means is that the burden is really going to fall on you to try to navigate this on behalf of your clients. And so with this conversation and going forward, please, let's make sure we stay in close communication. The last big takeaway I want to say here is documentation on your different type of work requirement satisfying activities, as well as potential exceptions, we can all start thinking about, do you have the documentation? Do you understand what kind of documentation you may need? This is going to be a chicken egg exercise because to some degree, you're going to have to wait to see what your state government, state Medicaid agency is going to require. On the other hand, as community organizations, you can begin to socialize, making sure folks understand what the work requirement activities are, what the exceptions may be, and the paperwork you can start to begin to put together. Next slide. This just really recaps the administrative burden, which is really going to be the set of barriers that our communities are going to face. We talked about documentation, understanding notices, so making sure your address is up to date, making sure you understand reporting deadlines, appealing incorrect determinations. The next area I do want to highlight is, if you have a traditional job or if you're enrolled in a traditional volunteer organization and activity where the agency can provide documentation, or you're enrolled in an educational program or voc training activity. But I do want to highlight these are a couple areas I want to ask all of us as AA NHPIs to consider. The gig economy, the number of gig workers within the AA and HPI communities is continuing to grow. There's not a whole lot of data here, but I wanted to benchmark what we were able to find. About 1 in 5 or 20% Asian Americans are gig workers. In California, there was some data we could find, and what we found is that Native Hawaiians and Pacific Islanders are more than twice as likely as Asian Americans, so almost 30% in the gig economy. Unpaid caregivers. We tend to live in multi-generational households. Candidly, I think this is a growing trend because our population is aging. And so adults are serving as caregivers. And about a third of Asian Americans are providing, there's a little typo here, about 20 plus hours of care per week without pay. And more often than not, this is unrecorded. So these two areas I want to highlight because when we think about documentation that will be needed within our community and together in your coalitions, please start to think about what can you do at the local level to try to make documentation of these activities a little bit easier. I mentioned that people are really talking about the definition of what does it mean to be medically frail. The key point here is that the HR1 had a definition, the CMS definition is much narrower, and as a result, there is currently litigation unfolding. Next slide. So again, the importance of public commenting, either with my staff or with me, if you ever want to have a longer conversation about federal rulemaking, please let me know. We spend a lot of our time and effort on this. But in short, as I stated, it is a federal agency's guidance to states and stakeholders. In this instance, to state Medicaid agencies, as well as those that are going to be impacted. So hospitals, nonprofits, many of us fall under, will need to follow the CMS rulemaking. Submitting comments, and this is why we really want to hear from you. We want to hear from our community leaders today. Why submitting a public comment is so critical. Typically, a federal agency will take into account all of the public comments it receives. There was a federal rule just the other week on federal granting or federal financial assistance, and the government received almost 500,000 comments. A federal agency is required to review every comment that it receives. I'm one of those recovering attorneys in Washington, D.C., and so documentation is so critical. This is a form of storytelling. This is a form of making sure, as AA and HPIs, our voice is visible. And this is one way we can do that by making sure we submit comments. This can be a complex process, and it does require some policy expertise. So traditionally, please know that the health forum, we keep an eye out for these federal regulations. And when we think it's very critical to make sure there's an AA and HPI vocalized perspective, that's when we will submit comments. And where we can, I want to be very transparent. The health forum, we will also invite our national AA and HPI partners to join in together. And typically, this is the National Council of API Physicians, the National Asian Pacific Council on Aging, APEAL, Filipino Nurses of America, Association of America, as well as the Association of Asian Pacific Community Health Organizations. And that is our intent here. You frequently hear from my staff where we will reach out to our network and ask you, do you have real-time, just-in-time stories? The specifics are really, really important, and this is why we ask you for your stories. Okay, so next slide. I know that was a lot, and here what I want to do is make sure we have the chance to hear from our terrific colleagues here. Muriel Abbas from the Coalition for Asian American Children and Families up in the great state of New York. Christine Barker from Fresno Immigrant and Refugee Ministries from California. Marcina Langgreen from Marshallese Educational Initiative from Arkansas. And Henny Orr from Refugee and Immigrant Voices in Action. So thank you so much for joining with us. So if you don't mind, why don't we go in this order? So Muriel, could I ask you to start? Let me ask each of you. Let's try to do maybe a couple of rounds here. If you just briefly start with, what is your role when it comes to helping your community and family members navigate Medicaid? And then question number two is maybe you could share one highlight, maybe two highlights, the questions or the challenges you're already facing. And I know the big challenge here is making sure we can hear from all of you. So let's try to make this a little bit of a lightning round, and then we'll come back again. So, Miral.
Hi, everyone, and thank you, Juliet and the Asian and Pacific Islander American Health Forum for inviting me today. My name is Maral Abbas, pronoun she, her, hers, and I'm the Health Partnerships Coordinator at the Coalition for Asian American Children and Families, or CACF. We are New York City's only Pan-Asian Children and Families Advocacy Organization, and we work to advance health equity for Asian American and immigrant and other historically marginalized communities in New York and beyond. So at CACF, through my role, I get to coordinate our Access Health NYC initiative. We are a collective of 37 community-based organizations, and we work at the intersection of community-based research and programming and also policy advocacy. And then also our Patient Navigator initiative, which very top of mind today with today's conversation. That initiative helps New Yorkers enroll in and maintain health insurance and coverage. So just briefly in regards to the first question about the kind of work that I provide or CACF provides, I just want to start by clarifying that CACF, it's not a direct service provider. Instead, we get to partner with community organizations that do provide those direct services, for example, assistance with Medicaid enrollment, benefits navigation, and connection to other essential services such as employment, education, housing, and so much more. But what makes these services so special and what we get to support and promote, especially through our budget advocacy work, is the trust that these organizations have. They are rooted in the very communities they serve, staffed by the people who speak the language, understand the culture, and share lived experiences. And that very trust and connection allows our organizations to reach people who are often missed by traditional healthcare systems. And whether it's providing health education at community gatherings, for example, a lot of our organizations work directly at mosques, schools, churches. They also educate the very community members who are closest to the people they're serving, for example, pharmacists, salon workers, community health workers, all to overall share health information and meet the people where they are when it comes to important issues such as, for example, now Medicaid enrollment. And what we're hearing right now is that this work is becoming increasingly difficult. A lot of our community members and partners are seeing a lot of growing confusion around Medicaid eligibility, which is leading to declining enrollment. We also are, and we'll talk about this in a little bit, a lot of increased fear and confusion with public charge and what these mandates, for example, mean for them, and everything is all getting mixed up. And it's affecting people who need care. And people think that even though with all of this going on, they don't qualify for care anymore, but they really do still qualify for care. So all in all, as we discuss Medicaid work requirements, it's really important to recognize that these policies are being introduced into an environment right now where fear, barriers, and misinformation is all already limiting access to care. And that's what makes the role of our CBOs, people on the ground, so important and essential to ensuring that communities get the care that they need.
Great. Thank you so much. Christine, I'm going to jump to you.
Good morning and afternoon, everyone. I'm Christine from Firm in Fresno in Central Valley of California. And at Firm, we work with a number of AAPI communities, Hmong and Lao and Khmer and Afghan. And I want to just, I was nodding to everything Maral was saying because all of that we're also seeing here. There is so much confusion about who is eligible for what and starting when, especially in California, we do have state-funded Medi-Cal is our version of Medicaid. And so there's been a lot of advocacy about Medi-Cal, which is important, but that also sometimes can lead to confusion because when we're in the media, we're talking about what could happen. And so people think it has happened, even though the legislature moved some things around and hasn't happened yet. For example, with our dental coverage of Medicaid, there's just a lot of confusion being put into place. At Firm, we do offer assistance with enrollment. We have community health workers who do health navigation and also navigation around all of our social determinants of health systems and social service enrollment and navigation. I think the other challenge that I want to lift up is folks are opting out of government-funded care, even though they are eligible, because of they are so afraid of immigration enforcement, regardless of immigration status, regardless of whether or not in the before times we would have thought they would have been at risk, particularly for folks with refugee backgrounds. Who have lived through government transitions already once in their life. Some folks are just not taking any chances. They are going off grid. They are canceling their cell phone that the government pays for. They are canceling their insurance. They are moving. They do not want to be found. And so how do we support them and their health and their autonomy? And also recognize that there's some legitimacy to those concerns, even though we might have different takes on it.
Thank you for that. Marcina, welcome from Arkansas.
Good morning, everyone. My name is Marcina Lindgren. I'm the operations coordinator at the Marshallese Educational Initiative based in Springdale, where the largest population of Marshallese reside, aside from the Marshall Islands. At MEI, I work alongside our team to help Marshallese and other underserved families access essential healthcare, education, and community resources. Our main goal is to really reduce barriers caused by language, cultural differences, and complex systems so families can receive the support they need. And I really do have to echo and agree with Meryl and Kristen that we are also seeing a lot of those challenges ever since the soft launch in Arkansas. We are already hearing a lot of confusion and fear. Many community members are really unsure whether the requirements apply to them. They worry that they could lose coverage despite working or qualifying for an exemption, and they're really concerned about, navigating reporting requirements because of the language barriers and limited access to culturally appropriate information. I think the one of the biggest challenges we're facing right now is that word of mouth has a significant impact within the Marshalls community. One person's negative experience with Medicaid can really quickly spread through extended families, churches, social networks, and this discourages others from applying or renewing their coverage, even when they may be eligible. And so this really highlights the need for culturally and linguistically appropriate outreach and, trusted community navigators like our organization and really clear education about eligibility, documentation requirements, and policy changes.
Thank you so much for that. Henny, hi, how are you? Welcome.
Hi. My name is Henny Orr. I am a founder and director for Refugee Immigrant Voices in Action. Glad to be here. Formerly, we work with Embark. I was the co-founder for Embark, which is Ethnic Minorities of Burma Advocacy and Resource Center. And in 2024, we split into 3 different organizations. The programs that we run at REVA are statewide and it's immigrant and refugee led. We've had an AmeriCorps program called REVA Corps that has about 40 AmeriCorps members per year, 85% of whom are of immigrant descent that work statewide. We also have an impact incubator, which really focuses on how do we strengthen immigrant-led groups. We are very boots on the ground, get grassroots. And through that impact incubator, we have worked to launch Afghan partners. We are now working with the Latino group, things like that. Just to provide some context about Iowa is a deep red state. We have an English only law. And it was already very challenging to begin with. Other than culturally specific domestic violence, sexual assault organizations, there are very few. There's only a handful of funded immigrant and refugee organizations. So right there, we see that there is a huge gap. So there are no materials being translated in our state. So that's we are, after things have changed, we have seen that foundation funding, all of that. So we are one of a few, and we are seeing so much in the community from people being cut off from SNAP. These are refugees, and many refugees, including Afghan and others, who apply for green card. It has just stalled. So not having a green card means that you're going to get cut off. We're seeing people get letters and coming to us last minute. It's about a 10-day turnaround time to appeal whatever benefit they've been denied, Medicaid, SNAP, any number of things. And of course, it's in English. And so we have started to work almost like it's almost worse than COVID-19, where there was just a lot of resources. And this is on top of, we're just trying to do this as volunteers and trying to help get these benefits reinstated, but oftentimes that fails because they're doing things like, there's policies such as sponsorship deeming, where they're looking at, if someone's been here even 9 years and they're a green card holder, they're still going to ask for information about the sponsor who brought you over for income requirements. And there is, of course, a lot of reluctance to provide any information. We have some free clinics that I've been starting to work with to figure out what we're going to do with the Medicaid requirements, and they are overwhelmed. I mean, people are traveling hours outside the state to try to get care. People are like many of our the colleagues, they have started to approach me, some of the community members, to ask about voluntary departure. It's also combined with workforce requirements where we're working with people who are cut off, who are unable to work because they don't have the green card documentation or they're an asylee, and we're seeing a lot of asylee applications being denied. So we're really in a really terrible position. And even with workforce development, if someone's, just looking at the requirements, we've had so many people try to get jobs, but then someone would apply, but no one's actually helping them set up an email or understand how to use an email. There is not that kind of navigation system here, which is direly needed. So that's just a little snapshot. Thank you.
Thank you, Henny. Wow. Okay. Thank you for that. You know what? I'm going to take moderator's prerogative here. I think you've helped to lay a really good foundation, a lot of similar, same experiences, and then also where you sit. You're also sharing different perspectives. We very intentionally wanted leaders from different states, both states led by Democratic governors as well as Republican governors. So thank you again for all of you joining. And as we're connecting here for the next few minutes, I do want to ask us to think about, Henny, I was jotting down some notes, right? Appreciating that the infrastructure in the state of Iowa is going to look very different than the state of California. And so if there's something the health forum can do or through our community network, where at least if it's some translated materials around the basics, just so that we can scale the distribution of some cleared, vetted information, that's certainly something the health forum we would like to try to do together with you and our other partners. Let me take a quick look at the chat here, the Q&A. Let's see. Okay, so Valerie, thank you, Valerie. I'm just going to use first names. If you do share your name, you're welcome to share your comments anonymously as well. Is there a collection of translated materials we could put together? This is certainly one of the roles that Health Forum did play during COVID and then during vaccination. So please know internally, together with our national coalition partners, we're also discussing how do we make sure some of the accurate vetted information can be available to scale that is also accurate and available in different languages. And as I'm getting to the next comment, I also do want to share, if some of our participants who joined us today, if you're not familiar with a national coalition called Protecting Immigrant Families Coalition, I do want to ask you, go ahead and Google it. It doesn't cost anything to join. It is a wonderful national coalition with local state partners. It's a network of 800 friends. And the Health Forum happens to serve on the executive committee. And at least for this year, I'm actually serving as the chair of the executive committee. The reason why I'm sharing that is this coalition, we really do work in coalition for a lot of the reasons that our speakers have already highlighted. So here's a great question. Are there any county offices that have started working with local CBOs to certify entities for community volunteer hours to meet the work requirement? Or are there any other CBOs who have experience in certifying volunteer work hours that can provide some insights on how this can work? These are two critical questions that the Health Forum is tracking. And so if anybody on the call, if you want to raise your hand, please do. I see Christine is about to. So let me jump to Christine, and do know that on these two questions, this is definitely a call to action, and the call to action needs to be locally, together with your local public health agency, together with your coalition partners. This is a great opportunity. If you've not yet worked with your local Latino organization or even the NAACP or National Urban League, these are national partners that the Health Forum works with exactly on these issues. If you need a facilitated introduction, we're happy to try to help facilitate that. Let me jump to Christine because I saw your hand go up. Yes.
Yeah, I wanted to say that at least in Fresno County, we're seeing and I think I heard this from others too. The SNAP work requirements got a lot tighter as a part of HR1, and so the SNAP work requirements are already being into play. And so we are in conversations with Fresno County. The DSS department is working to expand partnerships with different places for both volunteer hours and work experience, which will count for continued access to SNAP or CalFresh, as we call it in California. And so I would just recommend to any CBOs like to reach out, and it's going to be SNAP first before it's Medicaid, or it's already SNAP. And so hopefully you can find someone willing to partner in your county Department of Social Services who's administering it to get more things. And we're already thinking about how can we create more opportunities for people to volunteer in a way that can help them stay on benefits, but also helps the community as a whole.
Yeah, thank you for that, Christine. I am intentionally this year, folks might know the health forum, we're turning 40 this year. But intentionally between our policy community engagement team, myself included, for me, I'm prioritized trying to visit different community partners across different regions in the country. So I've sort of done the West Coast a little bit, hit Chicago, and did hit Boston, and also I need to get down to the South. So Marcina, maybe you can help me and maybe I can make my way to Arkansas. Um, in addition to your Department of Social Services, for you, it may be your local public health agency. So, for example, in the San Francisco Bay Area, which is just monstrously large, they are actually hosting and wanting to host community engagement meetings. So, if you're a community leader, write that email, make that phone call to your local public health social services agency. Maybe it's your city council member, you alone as an organization or together. Somebody put that email request together and have your local partners sign on to it and say, please host a town hall on this topic now. That way your local leaders can hear from you. I do know in Illinois, one of the agencies I visited with, they said even as a result of HR1, they have not experienced funding cuts while they lost federal funding between their local and state government agencies. They have found supplemental funding. Now, granted, I think that's a friendlier state to immigrants and refugees and asylees. But Christine, thank you for the point that you're making. Let's see. Do we officially know if ICE has access to immigrant refugee data if they are enrolled in government assistance, or is this misinformation? So I will share with you that it was last year that CMS at the federal level, I do want to say this was a Trump administration decision. So for this White House administration, they made the decision and the agreement that CMS could share enrollee data with ICE. Now, I will also say that if you're following the news with a lot of these, if a policy decision at the federal government hits you the wrong way, I just want to say more likely than not, some of our legal advocacy partners have probably filed a lawsuit. So I do know on this issue of HHS and CMS wanting to agree to share data, beneficiary data with ICE. There has been litigation on this. I don't have my legal notes here in front of me, but I do want to say in part I can answer your question. But this is a good question to ask and for us to be mindful of. And earlier, one of our friends dropped in the chat the name of Protecting Immigrant Families Coalition. Again, the health forum is a part of the coalition. And so if you go onto their website, we are intentionally trying to centralize all of this information and these updates, protecting immigrant families, or PIF for short. As a coalition, we do focus on the public benefits. So it can be Medicaid, it can be housing assistance, it can be SNAP and TANF. So this is a really great resource. If you don't want to yet join another coalition, that's okay. But bookmark the website because it has wonderful information. And just like Henny highlighted, we are all facing bandwidth issues. We are being avalanched with so many policy changes and community needs, anxiety, and confusion. So really trying to do this in coalition is going to be key. Okay, so I think I answered that one. Hari, great. I'm so glad you could join us. Does anyone have a screening instrument to determine Medicaid eligibility related to work requirements and immigration status requirements as patients and clients come forward, arrive for appointments? That's a really good question. I don't know the answer to that question. So let me make sure we document this and take it back. So thank you for that question, Harry. And I think that's a really, great idea. For those of you that also work with a larger senior population, and I did highlight that for elders, our seniors, about 500,000 of our folks are dual eligible for Medicaid and Medicare. And work requirements are also going to impact some of our seniors, believe it or not. Another national organization and partner that I want to throw out there, they do wonderful advocacy work, outreach work, educational campaign work, is an organization called Justice in Aging. I think they do a fantastic job of translating policy information into plain language. I myself will always check what their latest information is. They are also a member of the PIF Coalition, but for those of you that work with a larger senior population, let me ask you to, bookmark that organization as well. The one thing that I want to add here, where it comes to Medicaid, I do try to sit in different areas, and I'll share with this community network. I do serve on the national board of the Bazelon Center for Mental Health Law. So that it's a premier litigation disability advocacy organization. They appreciate hearing the AA and HPI community's voice and perspective. And quite candidly, I learn a lot, and it's a great resource back for me to be able to bring back to the health forum and share with the network here. So between Bazelon Center and the National Health Law Program, I do want to highlight that when you are helping your clients navigate Medicaid eligibility, there are some folks that may be eligible for Medicaid under different categories of eligibility, meaning some of your clients may be eligible for Medicaid through the disability avenue. And so I want to bookmark that for you and explore that because that is going to have different work requirements. It may be easier to be eligible for certain exceptions. And it's also going to depend on what your state does when it starts to carve out exceptions, how it defines medical frailty. So let me just tag, there are different eligibility categories for Medicaid, and make sure you begin to develop a working knowledge on the disability eligibility side of Medicaid. Okay, thank you. Let me see, I'm gonna look at our panelists. I know you have a wealth of information. Do you have a call to action, and or do you have a request that you want this community to hear so that we can all write down the same things so that when you talk to your local leaders, we can all amplify what we are all individually experiencing. Because I firmly believe what Henny may be seeing on the ground in Iowa is going to be unfolding, probably maybe Nebraska, Missouri, and some of the other states where there's a low to very low infrastructure for AANHPIs and or it is a very unfriendly immigrant community or very little resources. I do appreciate that the organizations who have a significant refugee asylee clientele, I know you're going through really, really extraordinary tough times right now. So let me look at our terrific leaders here. Do you have a call to action? And or do you have a request that you want all of us to make sure we hear today? So let me start with, how about I go Christine, Marcina, Henny, and then Mural. I'll go in that order. So I'm not putting you on the spot, trying to give you a few moments to think about what you want to share. Christine.
Great. I think two big calls to action that we're trying to include in all actions is exactly what Henny brought up earlier, which is for refugees who are here who didn't receive their green card before the processing ban. That is a huge gap that is only going to grow larger and larger and larger. And there's always that could be addressed, but definitely Congress needs to hear that over and over and over again. I think other sort of response call to action is to really work with partners and work with your local entities to figure out how we can get people provide as many pathways as possible as a community to keep people connected to care. And so for funders to think about funding care, even though you think there's public money for it, there's not anymore, or there won't be. The more we can keep people on coverage, the less strenuous it's going to be to try to get them reapproved. So recognizing that enrollment support and maintaining coverage is going to take up even more time and is really hard to bill. Also, to everyone who's been pushing us to focus on community health workers, recognizing that our most at-risk people are no longer going to be eligible for Medicaid. We need different pathways and we need different ways to promote community care and community health. Thank you.
Thanks so much for that, Christine. Thank you. Marcina.
Well, I mean, our call to action is simple. What we tell our Marshall's community is don't wait until you lose your health coverage. We really encourage every Medicaid recipient to learn about the upcoming work requirements, update their contact information with the state. We always encourage them to respond to all Medicaid notices, and if they need help, to come to our offices. Many people may still qualify for Medicaid or for an exemption, but confusion and paperwork can cause eligible individuals to lose coverage. And as a trusted community organization, MEI is committed to providing cultural and linguistically appropriate education, enrollment assistance, renewal support, and really advocacy to ensure that all Marshallese families understand their rights, and if they meet any applicable requirements, and really maintain access to the healthcare that they need. You mentioned a town hall earlier, and I was just speaking with our council general about hosting a town hall. And so, number one thing we're going to do from now on until January is educating the community, and that's through churches, community meetings, town halls, and a lot of social media PSAs in both English and Marshallese. And so that is our goal.
That's wonderful. Thank you so much, Marcina. And for our local partners, when you do have your if you have a social media campaign or something you push forward, um, feel free to share a copy, reach out to our community engagement team. You can reach our whole team at community engagement at apiahf.org. If you're inclined to tag the health forum, we want to be able to amplify. So our CE folks, our social media folks, when we see your things, we like to retweet or re-forward. So please let us know. And both community engagement and policy, we're very intentionally trying to do these kinds of virtual convenings at least once every 2 months. Some people have asked us, oh, can you do it every month? But also we know how busy you are, so we want to make sure when we ask an hour of your time that we make it count. If you do have materials that you want to share with us, we can be that facilitator and share it back out with our community network. We have a separate listserv that is just for our community partners. So this is all about let's share what we can. Thank you. Henny.
Yeah, thank you, Julie. I would say as a call to action for people to reflect and think about what it looks like to support states like Iowa and the South and the Midwest. And a lot of times I'm on calls and it does not apply to us. We, like everyone, we are very much about community centered, being responsive. We are trying to build coalition. We are trying to build community. But when people say, "Hey, look, my water quality, my water is like mud," or "I don't have enough food," so we can't divorce social services and social impact, and yet uh, we are just struggling to get some attention and to build infrastructure here. We're part of many different national groups, and we started to fall off because we don't have the time, right?
Yeah.
And, I mean, we really are at a place where we would consider, well, should we close, right? And there isn't something in Iowa like this, but that's the reality. And, whatever kind of capacity building support or resources that can be out there, that would be wonderful. So, yeah, I'm sure the situation is similar in many states.
Thank you, Henny. I'm going to keep you on my list, and I know you're super busy. I would love to try to find some time for you and me to follow up and see if there's something we can figure out on our end. So thank you for that. Miral, bring us home.
Thank you, Juliet. Well, I want to just thank you all for all the narratives and insights that you all shared. I guess to round it out, I want to echo everything that everyone mentioned. And again, just reiterate first, of course, a call to action is to invest in our frontline organizations, all of the work and organizations that we're a part of. Our CBOs are not just enrollment sites, they are trusted messengers, cultural navigators, translators, and so much more. And for our community, sometimes the first place that they turn to when they don't know where else to go. And in this current atmosphere where policies are continuing to evolve, it's our work that needs sustained investment, information, and meaningful partnerships, even across states like all of us, so that we can continue meeting the communities where they are. And even with all these policies, we now have limited funding as well, but we still see our frontline organizations step up by going to schools, libraries, consulates, all those spaces that I mentioned, even expanding outreach on social media, whether it be Instagram or even like ethnic platforms like WhatsApp. And our community members are telling us that these culturally responsive approaches are working and they are enrolling and trying to understand. And that's why we need to keep investing in them. And even here at CECF, our work really comes down to being a bridge between communities and local leaders and trying to inform critical budget and policy decisions. We just came out of a very critical spring budget advocacy season. We were meeting with countless council members and our different initiatives. For example, one that we run, Access Health NYC, to try and get more funding with everything that's going on. And I think just to kind of round it all out to end sort of on the very purpose of today's call with the storytelling is that we need to continue listening and elevating community voices like on this webinar. Policymakers need to hear firsthand how these changes affect not only healthcare access, but are impacting families in so many ways like financial stability, mental health, public health, and overall well being. And this is often information that normative data practices or surveys or quantitative data can't fully capture. And that's where storytelling, where even like if it's one or two impactful stories of how a family's economic or health well-being is being impacted, it can really mean a lot to sway policymakers or other elected officials who are part of these decisions. And a lot of these times, those platforms to share these stories come from, as we were mentioning, I appreciate the town halls, the public comments. In New York City, we take part in a lot of city hall testimonies. I've gone to countless to really center and share unique community experiences. And really bringing these on the ground perspectives into policy is essential. And so, right now, I think storytelling is something that we've been repeatedly hearing a very powerful tool to keep using now and for the foreseeable future. So, I'll pass it back to you, Juliet, but thank you everyone for sharing and for this opportunity.
Thank you so much. My staff were pinging here. Well, thank you for this. I think elevating community voice, I mean, that is probably one of the most important roles that the health forum can help to facilitate. I would encourage somebody on today's panel said this, and it reminds me of a conversation I had last week. You know, especially maybe in some of the red states. I do want to say in Washington, D.C., talking about access to healthcare is also a economy issue. Seems to resonate with some of the more conservative elected officials. Again, don't hesitate to reach out to our community engagement team. The Health Forum, we are working on that public comment letter. If by chance you have a story you want us to try to include in our public comment letter, again, we're going to be submitting our letter either July 30th next week. The deadline is the 31st. If you have a policy question, you can email policy@apiahf.org or visit our website, apiahf.org. I hope we get the chance to see some of you at our November Voices conference. For any specific stories you do have, especially if you can get a little bit more granular on how many hours it may take to help an individual navigate the Medicaid application roll. That's the kind of stuff, right? Like I will go meet my client and this is what is required. I want to make sure we can get some of those real granular stories. I know you're busy. If you want to just like record on your iPhone and like, just send us your video recording, or if you want to give us a call and we can just take down your story, we can do that. But from the bottom of my heart, thank you for our speakers and everybody who's joined today's call. And just really, really grateful for what you do in building this community together. So please take good care of yourself, and I look forward to talking with you soon. Take care, everybody. Thank you.